Howdy, y'all. This is Dr. Jeff Jarvis. Let's talk mask ventilation, shall we? Now, while the bulk of what I want to talk to y'all about is the most effective way to ventilate a patient using a BVM, I want to first touch on the indications for assisted ventilation. We talk about the bundle of care that goes with effective manual ventilation, and we call that max BVM. That's just the word for it. We use this bundle in several circumstances. The first is cardiac arrest. Now, the rate and volume of ventilation in both adult and pediatric arrest, that's an area of intense research interest right now. Now, because of this, information such as how often and when to ventilate is rapidly changing. Please refer to the cardiac arrest protocols for this information. Number two, inadequate minute volume. Now, y'all remember that minute volume is tidal volume times respiratory rate. Patients may need support for either inadequate tidal volume or inadequate rate. In-tidal CO2 waveform is a good approximation of both tidal volume and rate. Now, in general, adults should be ventilated with 100% oxygen to a goal saturation of greater than or equal to 94% and a target in-tidal CO2 of between 35 and 45. Now, pediatric patients should be ventilated at 20 times a minute, and neonates should be ventilated between 30 and 60 times a minute. Now, that's once every 2 to 3 seconds. All right, with that out of the way, let's get into max BVM. This, as I said, is a bundle of care that's aimed at providing a tight mask seal, maximizing ventilation, replacing as much inert gas like nitrogen as possible, keeping the airway passages open, and protecting against aspiration. Specifically, max BVM includes using the following things. Number one, use 2 clinicians to ventilate, one to make a 2-handed mask seal and one to gently squeeze the bag. 2, placing the patient into an ear to sternal notch position. 3, using both regular nasal cannula oxygen and BVM oxygen with a reservoir, of course, set to maximal liter flow. 4, using nasal and/or oral pharyngeal airways. And 5 is aggressive use of suction. Now let's go through each one of these steps. Now, unfortunately, most EMTs and paramedics are not adequately trained and don't adequately practice making a good face mask seal. We were all taught to use a one-handed EC clamp. Please stop doing this. To put it bluntly, we kind of suck at it. It's only appropriate in this system when you're the only clinician available to manage the airway. Otherwise, just use 2 people and do the job right. We should instead use the more effective 2-handed thumbs down seal where your fingers are lifting the mandible up into the mask while your thumbs are facing down toward the patient's feet, and your thumbs are what are holding the seal. Now, because this is using the thenar eminences, these little palmar pads at the base of our thumbs, this is also called a thenar grip. This 2-handed seal, this thenar grip, delivers higher tidal volumes with less leak than the traditional one-handed method. All too often, when we realize we don't have an adequate seal, we simply just press the mask down harder onto the patient's feet or face. I mean, we could push it down into the feet, but really I meant face. Don't do this because this is counterproductive. It actually presses that mandible down posteriorly, and that inadvertently occludes the airway. Now, there is a good reason you probably don't remember being taught the head tilt chin push method of opening an airway in school. Well, you didn't learn it because you weren't taught that way because it doesn't work. But that's what we do every day, both in the field and in the hospital. So instead, what we want to do is use our fingers to lift that mandible up into the mask. We don't push the mask down onto the mandible. Remember, lift, don't push the mandible. Now, if the patient needs assistance with ventilation, you have one person making a good 2-handed seal, and the second person is providing gentle ventilation. Next up, positioning. Proper positioning is key to effective ventilation and oxygenation. Elevate the patient's head and place them in an ear to sternal notch position. Now, this has the neck extended and the face parallel with the ceiling, assuming they're lying down. The ear canal will be level with the sternal notch, just like you see it in my buddy here. Now, because I like to think I know my audience, I'm pretty sure there's another way of describing this situation that might, just might, paint a better picture. Picture this, if you will. Say a friend, a colleague, maybe your partner after a long shift. After the shift, just to be clear, y'all are in a pub and you both got a fresh pint. Now, your buddy, not wanting to spill that precious beer, your friend is going to extend his head forward to the beer instead of just tilting that full pint of glorious nectar back towards their head. This is what I call the pint sipping position. In reality, it's just ear to sternal notch position with the person standing up. In addition to putting the patient in pint sipping position, elevate the head of the bed to 30 degrees if you can. This helps decrease the chances of aspiration, but it also improves oxygenation and ventilation, particularly in those patients that are, say, 2 to 3 Texas units big. Now, we want to maximize oxygenation. Y'all may have heard that too much oxygen can be harmful.
Don't you love oxygen? Me too. But it's killing us.
While this may be true in some circumstances, it most certainly does not apply during pre-oxygenation or manual ventilation here. Give them as much oxygen as you possibly can while you're managing the airway. This is especially important if you're going to intubate, and that is a process where they need to be apneic for. Maximize oxygenation while mask ventilating and then titrate down to the lowest fraction of inspired oxygen, or FiO2, that you can to maintain the saturations at or above 94. So start with it all the way on. Once you've established your airway, you can start titrating the oxygen down. Just keep it above 94. Now, use one oxygen source for the BVM and another for the nasal cannula. Use the real nasal cannula, not the Entitle CO2 nasal cannula. That one is for sucking. The regular one is for blowing. It gets way more oxygen through it than does the Entitle. Turn both of these sources of oxygen up as far as the regulator will go. If you're a Spinal Tap fan, remember, crank that sucker all the way up to 11. And if you have no idea what I mean, well, search YouTube for it. But in the meantime, just turn it up as far as it's going to go. Now, on quite a few regulators, this means that you can actually go past whatever the highest number on the regulator dial is. In other words, 11.
Why don't you just make 10 louder and make 10 be the top number and make that a little louder?
These go to 11.
Using a nasal cannula under a BVM does two things. First, it provides an extra source of oxygen to further increase the delivered FiO2. And most importantly, it allows you to easily transition to apneic oxygenation during the intubation or supraglottic attempt. Make sure you have waveform capnography before, during, and after the invasive airway attempt. In addition to confirming tube placement, the waveform can also be used as an indirect measure of tidal volume. Now, we typically try to assess chest rise to judge the adequacy of ventilations. Let's be honest, y'all. In Texas, in the age of McDonald's and taco joints on every street corner, our patients, well, they have pretty large chests. You may have noticed this. We're making some pretty big boys out there, y'all. Truly judging chest rise, it's a bit of a crapshoot, and we're not very good at it. Just because of those tacos. Waveform capnography, on the other hand, could care less about the tacos. It allows us to estimate tidal volumes very nicely. We ought to use it. Make sure you have a good 4-phase waveform with every breath. Now, waveform Entitle CO2 is also the most sensitive and specific means of verifying invasive airway placement that we have. And finally, it is the best way we have of continuing to monitor placement and function of any airway, including mask ventilation only. If you lose the waveform, you have to troubleshoot that problem. Find the problem, fix the problem. Don't just ignore the problem. If you don't have waveform end-tidal CO2 after you've placed an invasive airway, you are almost certainly not in the right spot. You need to pull it out. You need to do something else. This is a red hot danger zone. Please, please, please pay attention to your end-tidal CO2. So the next part of max BVM is a PEEP valve. Just attach it right onto the BVM. With PEEP attached in at least 5 centimeters of water, a BVM is capable of delivering oxygen without squeezing the bag. All of them can do that with PEEP in place. Now you add nasal oxygenation and voila, you have CPAP. Isn't that a cool thing? Now, our goal is to avoid squeezing the BVM in patients who are spontaneously breathing and who have adequate tidal volume, because doing so leads to increased interthoracic pressure. Increased interthoracic pressure decreases cardiac preload. That lowers blood pressure, and it increases gastric insufflation of the stomach. All those things, bad, bad, bad. We don't like. We want to avoid them.
And it's bad, bad, Leroy Brown, the baddest man in the whole damn town.
Now, I do, however, want to emphasize that we're only avoiding squeezing the bag in patients with adequate spontaneous breathing and adequate tidal volumes. Obviously, if they need to have assisted ventilations, by all means, please do so. Gently squeeze away at a controlled rate. Now, if we're intubating, we're giving rocuronium, and I promise you, unless that IV is infiltrated, rocuronium will make them stop breathing. When this happens, expect it. We're going to need to breathe for them, so start squeezing the bag. Now, once you've done all these things, if you're still unable to achieve adequate saturations despite a good tidal volume, despite maximal oxygen flow through 2 sources, despite a good seal, despite good positioning, and despite adequate respiratory rate, well, in that case, increase the PEEP. This often increases alveolar recruitment sufficient to raise the saturations up. Now, we got a short video. I found this one online through the magic of my incredibly strong Google Fu. It demonstrates the impact of increasing PEEP on lung recruitment and what happens when you rapidly turn PEEP off. This video is from sheep lungs that were specifically prepared to demonstrate the effects of PEEP. And by specifically prepared, I mean Dan Cohen at Wilco EMS and we found some sheep lungs, we tied them to an ET tube, and, well, we just went to town on it. So here we are bagging the patient, and we're doing it without any PEEP at all. Now, for the sake of demonstration, not that we're going to do this clinically, but in this video, for the sake of demonstration, I'm going to turn the PEEP all the way on. And you're going to notice that in between inspiration, the lungs are slower to collapse. That's the alveolar recruitment that we get from PEEP. The more alveoli that are recruited or opened up, the more surface area there is for gas diffusion, the more oxygen moves in and the more CO2 moves out. We like alveolar recruitment when we're trying to improve oxygenation. Now in the video, I'm going to turn the PEEP all the way off. Again, something I'm not going to do in reality, just for the sake of demonstration. And what you're going to notice is that the lungs completely collapse. So PEEP is good. We like PEEP. PEEP is our friend. Alveolar recruitment, we really, really like. But there is a potential downside to PEEP, and that comes into play in cardiac arrest. PEEP can increase intrathoracic pressure, and that can decrease blood return to the heart, which can reduce the amount of blood available for your compressions to move back out of the chest. So don't use PEEP in cardiac arrest. Now, much like respiratory rate and tidal volume, this stuff that I'm talking about is really hot topics for research. A lot of stuff going on. But for right now, until we get better evidence, don't use PEEP in codes. Now, a common cause for failed airway attempts is secretions. I'm talking vomit, beans, tacos, industrial strength beer. I'm sure y'all have never come across this situation, but I'm pretty sure I've never managed a clear airway in the field. Everybody seems to have eaten the entire Taco Cabana, washed it down with at least a keg or two. Good times right up until that comes up into your face when you're trying to manage an airway. Fortunately Fortunately, we have suction for this. Assuming it's available, it's on, has a charged battery, and we're using a large bore suction catheter. Now, we frequently call all suction catheters Yankauers, but we really shouldn't. Not all catheters are created equal, and this is something that your purchasing officer really kind of sort of needs to know about. We want a large bore catheter for that massive Texas size crap in the airway that we come face to face with. Now, I'm a big fan of the Decanto catheter, and I highly recommend it, despite the fact that my friend Dr. Jim Decanto is not giving me a single penny in kickbacks. I've gone all across this country hawking his catheter, not a single penny. Tell you guys, sometimes not having any conflicts of interest just sort of sucks. So use the great big suction catheter. That's the Max BVM bundle. This is how we want y'all to manage airways non-invasively and before placing invasive airways like an SGA or intubation. Guys, I hope this protocol review module helps you understand the assisted ventilations and bag mask ventilation protocol. As always, please feel free to drop me an email, send me a text, give me a call, or come by the office if you have any questions. I love hearing from y'all. Thank you very much for what you do every day. Take care, y'all.